Good evening and welcome back to the Lipid Panel. My name is Dr. Guy Mintz and I am the Chair of Programming for the Lipid Panel. This evening we have an excellent complex lipid case of the month, which I'm sure you're going to be very excited to hear more about. The Lipid Panel was conceived to give everyone an opportunity to have lipid experts in their living room. For those of us lucky to have in-house colleagues who can discuss these issues on a daily basis, it's a great way for all of us to have the same experience virtually. The Lipid Panel takes place the last Tuesday of the month, and we invite you to send in topics to myself or Chloe from the MNLA, and we will happy to discuss them and present them, and any cases that you may also have available for us. So without further ado, I want to welcome our expert panel for this evening's presentation. Dr. Alan Remele was going to join us from the NIH, but due to the government shutdown, there were restrictions for him being involved. But we have an outstanding panel. Dr. Dinesh Kalra is going to be our moderator. He's the Chief of Cardiology at the University of Louisville Medical Center in Louisville, Kentucky, and is a professor of medicine and radiology at the Louisville School of Medicine. He is an international expert in multi-modality cardiac imaging, preventive cardiology, lipidology, and infiltrative cardiomyopathies. Everybody's extensive biographies will also be placed in the chat. Our case presenter this evening is Deepak Vedamurthy, who is a second-year cardiology fellow at the University of Louisville, Kentucky, and is interested in lipidology and preventive cardiology. Our panelist this evening, Dr. Daniel Soffer, is a professor of clinical medicine on faculty of the Perelman School of Medicine at the University of Pennsylvania in the Department of Internal Medicine and Division of Translational Medicine and Human Genetics. He is Director of Education, Preventive Cardiology, and Clinical Lipidology at the University of Pennsylvania and co-director of the Preventive Cardiology Fellowship Program. He's also former president of the MNLA. Our other panelist this evening is Marina Cuchel, who is a translational scientist with a long-standing research interest in rare disorders of lipoprotein metabolism and the development of novel therapeutic strategies for these conditions. So without further ado, I hand the program over to Dr. Vedamurthy to present our case this evening. Thank everyone for joining us and enjoy our program.
Everyone, thanks for joining us today. I'm going to talk about an interesting case that we came across a few months ago. Let's start. All right, so this is going backward a few years. This is a 25-year-old lady who had no significant past medical history, who sought medical attention due to gradually worsening fatigue, low-grade intermittent fevers, right upper quadrant discomfort, and jaundice. She had no other significant past medical or surgical history. She had clean habits, no smoking, no alcohol abuse, never used any street drugs. As far as family history is concerned, she had a brother with a history of alcoholic cirrhosis. And when she presented to the emergency room with these symptoms, her vitals were quite unremarkable. Right. Her exam in the emergency room when she first arrived for medical attention was pretty much unremarkable, except for mild tender hepatomegaly on palpation. Her cardiopulmonary exam was unremarkable. Her neurological exam was normal. She had no lower extremity edema. She was ectric as well. And these are the initial set of labs that we obtained in the emergency room during her first contact. Her white blood cell count was completely normal. Her hemoglobin was slightly low at 11.4. Her platelets were normal. Her sodium was low at 134. Rest of the electrolyte panel was normal, and her creatinine was also normal. Her liver function tests were abnormal. Her total bilirubin was 5.2. AST and ALT were slightly elevated. Alkaline phosphatase was significantly elevated. In the same visit, she had a CT scan of her abdomen, which showed mild hepatosplenomegaly and no biliary dilation. She was hospitalized, trying to figure out what exactly was going on. She was started on antibiotics thinking that this might be some kind of an infectious problem, and was seen by the GI team during her hospital stay. As a
Okay,
part of the,
Deepak, I think we can just take a little pause here, and so what you have here is a young woman who's been apparently healthy, and now she's coming in with fever, right upper quadrant pain, hepatomegaly, and very abnormal LFTs, and jaundice, and a pattern of LFTs that indicates both an obstructive pattern and hepatocellular pattern. So maybe I'll ask Dan to start off the conversation. And Dan, I'm sure you've seen these people in the internal medicine clinic and on the floors. What are you thinking about right now? I'm thinking about as a cardiologist, well, could this be viral hepatitis? Could this be a tumor? Could this be some sort of drug inducing? But feel free to chip in. And what are your thoughts right now?
Thank you, Dinesh. You're much more open-minded than I am. I happen to know that I'm in a lipid panel right now, so I know it's going to be something lipid related. And I will obviously have thought of a lot of those same things. This is a sick patient. The hospital is the right place to do the initial evaluation, though it sounds like her vital signs are normal and she's not bleeding and she's not having trouble breathing. So the team better work fast in trying to get information because she's probably not going to stay in the hospital very long. There's not too much in the way of clues to what's going on in her background. She was previously healthy. The only sort of flag that is held up is her brother having alcoholic cirrhosis. And, knowing that she's presenting right now with what looks like an acute hepatic injury or an acute liver problem, I think it's reasonable to wonder whether or not her brother's history is related to what she has. Maybe what they were calling alcoholic cirrhosis was a compound of a little bit of excess alcohol with an exaggerated response that they attributed to alcohol. Maybe there's some familial pattern that's at play here. I think that's reasonable to consider. On the other hand, maybe her reporting of her alcohol intake is not complete. So it could be that this is alcoholic hepatitis that we're dealing with, though it doesn't have all the classic features of that. I think the things that point towards an acute liver injury here is the finding on the CAT scan of hepatosplenomegaly. So she doesn't have a shrunken cirrhotic liver that's being described by CAT scan, and suggesting that maybe there's a more of an acute process going on. It's hard to say. I'm not sure I would call this a direct hepatic injury as much as a biliary disease. She has elevated bilirubin and a markedly elevated alkaline phosphatase. So I think it points more towards biliary disease as opposed to hepatocellular primary disease. And despite that, her CBC is pretty normal for a 25-year-old woman. And the only other chemistry abnormality is a mild hyponatremia, which doesn't even raise an eyebrow in the emergency department. So I don't know that we've narrowed it down to anything or ruled too many things out at this point. But my guess is that since we're on a lipid panel, this is going to be lipid related.
I think you're very wise to say that last statement. Yeah, but you summed it up really nicely. You have somebody who's gotten acutely ill, and you have to consider the family history. At this point, I agree with you. The differential is very broad. I think we've been able to rule out a couple of things because of the CT imaging. So, there's no big bile duct stone, but things are still fairly open. This could be a viral illness. It could be autoimmune. I think we've ruled out big masses, which would have shown up, but I'd still want some sort of more imaging. I'm sure Deepak will give us imaging and the lipid profile, which we're all waiting for. So,
but this patient actually came to us. Yeah, this patient actually came to us from a different health system, so I was able to get only the big picture, but I do have it right here coming up next. So
By the way, did you see Susan asked a really great question in the Q&A? Is this patient taking any supplements?
Not that as far as documented in the chart. No.
Yeah.
Yeah. Good question. All right. So I think that hospital stay, she kind of stabilized and she was kind of felt that she was good enough to be discharged with close outpatient GI follow-up. So she was actually discharged towards the end of December and she presented to her GI office with an outpatient MRI already being done. And that MRI showed mild hepatosplenomegaly with biliary tree showing multifocal short annular structures that alternate with normal and abnormal segments, and that was suspicious for primary sclerosing cholangitis. Now, when she came to her GI doctor's office, all the autoimmune panel that was ordered in the hospital also turned back, and she was positive for ANA, rheumatoid factor, and PANCA. So as usual, she underwent a gamut of tests, including an endoscopic ultrasound with the liver biopsy, the picture of which is shown on the right side, which was consistent with primary sclerosing cholangitis without any fibrosis. Okay.
Right.
All right.
So team, I will tell you that if this person's showing up in my clinic, I know that since I have a dedicated lipid clinic, I'm already starting to think of things that are associated with PSC in terms of lipid and lipoprotein. So already moving in that direction. I will say, I guess one of the other, a couple lipid things come to mind with severe liver disease like this, and I'm sure we'll get to that, like the main types of primary lipid and lipoprotein abnormalities, and even some secondary ones. But knowing that it's an autoimmune problem and specifically PSC, then we're already starting to think about a cholestatic picture, like we mentioned earlier, rather than a direct hepatocellular injury. And so if we were thinking, oh, this is lipid clinic and someone's coming here with liver problem, maybe it could be lysosomal acid lipase deficiency related to that, but that's more of a hepatocellular injury. So I'm already I've already pushed that one to the bottom of my list of things this could be. And this is not the kind of liver injury that we see in our patients with hypobeta lipoproteinemia, other lipid disorders that can cause liver disease. Certainly the severity is much worse. And so the list has shrunk dramatically if we're really focusing on a lipid problem that this could be.
Exactly. And that's a great point. I mean, the vast majority of people with liver disease as severe as hers, even when they don't have a specific diagnosis, are going to have problems in a lot of the lipid parameters, just because the liver makes a lot of apolipoproteins, and any derangement of those, depending on the stage at which you catch a liver disease, is going to be accompanied with either very high cholesterol levels, at least early on, and then as the disease progresses towards cirrhosis, the cholesterol levels may go down. So important to know both the stage of the disease and the exact nature of the disease and the process that's going on. Is it more cholestatic, because it gives a different picture, versus more hepatocellular? And we'll get into that.
Okay. All right. So she was started on ursodiol, 500 milligrams 3 times a day. And she was seen at multiple centers, including the Mayo Clinic, for management of PSC. She was treated with various immunosuppressants, just out of, just to keep our focus on the lipid metabolism. I didn't go through the list of all the immunosuppressants in her entire course over many years. But the long story is that her disease progressively worsened despite treatment, and she developed cirrhosis. And by the time she arrived to us when she was 32 years old, while she was on all these medications, her liver functions were still markedly abnormal, with a total bilirubin of 6. AST and ALT are still in the 400s, 300s range, and alkaline phosphatase is now 2,000 international units per liter.
Those liver enzymes look almost identical to her presenting scenario when 7 years before. That's really remarkable.
Yeah, I think she had quite a fluctuating course. With some medications, it comes down and then it comes back up, and then she gets like a burst of immunosuppressants, then it comes down. So she's got like a fluctuating course over many years before she came to us.
Deepak, a lot of these patients have pruritus also and do great with cholestyramine. So something that also catches the interest of a lipid specialist. And she was the only thing she was taking though was the ursodiol.
Correct. That was the only thing she was taking when she came to University of Louisville for a liver transplant evaluation, actually. Okay. All right. So actually, even before she met our gastroenterologist at the transplant center at University of Louisville, she met a dermatologist because she was starting to notice some lumpy, bumpy deposits on the palms of her hands, some in her eyes, shoulders, back, and posterior elbows. And obviously, the dermatologist rightly figured that out. These were xanthomas, and they ordered a lipid panel. And this is her first lipid panel after, at least in our health system, after she was diagnosed with this liver disease. Her total cholesterol was 1100, triglycerides was 165. HDL cholesterol was actually high at 130 at this visit, and LDL was reported as unable to calculate.
All right, so a lot to unpack here. So she's had years of cholestasis, and surprisingly, I'm a little surprised that she didn't have a lipid profile before that didn't come to our attention, but at least this one is very abnormal. And it sounds like the skin xanthomas are also relatively newish. So let's look at those. So Dan, maybe walk us through Palmer xanthomas, and looks like she's got some tubuloeruptive xanthomas on her elbow. And you know, these xanthomas are reflections of what's going on with macrophages and foam cells taking up cholesterol, so or other compounds. So maybe just give the audience a little bit of an insight into what are you thinking in terms of these xanthomas.
Well, I guess it's not shocking to find xanthomas when the total cholesterol is 1100 in anybody, regardless of the cause. But you know, the two main conditions that I think of as causing palmar xanthomas like that are going to be, you know, familial dis-beta lipoproteinemia and lipoprotein X. And of course, you know, sort of without jumping ahead too much to the obvious diagnosis here, this is in a patient with severe cholestatic disease. This is invariably going to be LpX with this kind of context. And it's fun. You're right. I think it's funny that a lipid panel had not been available prior to this, but not shocking. You know, it's you know, the principal features of liver disease are more about the immediate life and death aspects of the development of ascites and encephalopathy and variceal bleeding and coagulopathies and infections. And I think it's not that unusual that the teams might not think about this other aspect of synthetic function and normal hepatic function, and not necessarily check a lipid panel. But I think at most centers, I think a lipid panel would be part of a hepatology evaluation, and probably would have been found at age 25 when she first came in, is my guess. And at least at our center, I know it's pretty standard. As a matter of fact, I would say the hepatologists are pretty nonplussed when they see this kind of finding. They're like, oh, yeah, just another, you know, total cholesterol of 1,000. And I have to remind them that this is a big deal and we better pay attention.
I agree. Just because getting to what exactly the lipoprotein is that's carrying all that cholesterol is super important. That's what we'll talk about. But getting back to the, you know, Palmar Crease xanthomas, you correctly pointed out. I mean, it's, you know, that really narrows down the diagnosis. So the couple of cases we've seen of familial dis-beta lipoproteinemia, they tend to be more orangish looking because you know, the remnant particles carry more carotenoids, and they're like give you that orange color. So that's supposed to be pathognomonic. That doesn't happen in everybody. Maybe in what, half of the cases of FDBL, familial dis-beta lipoproteinemia. The few cases of lipoprotein X, like you mentioned, we saw in our clinic, they tend to be more yellowish. They don't have as much carotenoid content, and it's more free cholesterol that gets taken up by the macrophages and forms foam cells. And the tubular eruptive xanthomas, those can be from any number of things, including things such as chylomicron, which we all see in patients come in with pancreatitis and very high triglycerides. They have these. They could have cholesterol in those. They can even be immune complexes. I've seen those kinds of xanthomas in people who have Waldenstrom's or multiple myeloma. So xanthomas can be very fascinating, and depending on where you see them, they can sort of clue you into what you're looking at. I don't usually see total cholesterol that high in outside of FH. And so you're right. I think this sort of pushes the diagnosis towards a certain type. We will get to, there's a question in the audience. What is the ApoB? And I think that's a very pertinent question. Dan, you're like one of the world's experts in ApoB, and you have a wonderful publication in the MNLA publication in the JCL last year on the value of ApoB, not just in risk prediction, but also in breaking down complex dyslipidemias and really getting to what is atherogenic versus what is not, and getting to the answer. So maybe walk us through how you would use an ApoB in this case, and what do you think it would be?
Sure. Dinesh, do you mind? I just want to point out that one of the early slides I show when I'm teaching the Foundations of Lipidology course is that the best thing about being a lipid specialist is that there really are no lipid emergencies. But I always point out that there's a couple exceptions. A brand new recognition that triglycerides are over 500, especially when they're over 1,000 milligrams per deciliter, should, if not be emergent, should get your urgent attention in case it's a brand new thing and you need to attend to it. But the same is true when you have a brand new finding of a total cholesterol over 500 milligrams per deciliter, that while familial hypercholesterolemia is not a medical urgency or emergency, there are things that are like LpX, which can be an urgent condition to recognize. And so I don't count it as an emergency per se, but I think the first time that I saw a case of lipoprotein X, it was in a patient who was already in the medical ICU at our facility. And it was really, frankly, too late to address because too many bad things had happened. And I'm sure we'll get to that as we talk about the clinical scenarios that can unravel in front of our eyes when LpX is present and the total cholesterol is over 1,000. But to the ApoB point, I think most of the attention to ApoB has been paid on thinking of it as a tool to estimate atherosclerotic cardiovascular disease prognosis and comparing it as the tool that we use primarily, which is the LDL cholesterol. And while I think it really does have an important role when there is discordance between the LDL cholesterol and the ApoB level, I think the one of the most important thing for a lipid specialist to know about ApoB is that it can help you determine which lipoprotein is abnormal. And Alan Snyderman and his group in 2007 published a very useful algorithm for using the total cholesterol, the triglyceride level, and the ApoB in a pre-specified way to figure out which lipoprotein is elevated, which is very useful when you don't have access to ultracentrifugation and beta quantification, which almost none of us have access to that readily anyhow. And so as a bedside tool, if you have those three parameters, total cholesterol, triglyceride, and ApoB, you can sort out which lipoprotein is elevated. And if you know the lipoprotein, then you can work backwards from there as to what clinical syndrome you have. And I've tried to make that point many times in public and presentations. And so, and this is one of those cases where you're not even given an LDL cholesterol, thankfully. But you can work out that it's only a couple types of lipoproteins can be elevated in this scenario where the triglycerides are only mildly elevated, and it's going to be LDL or it's going to be LpX or so those are the options at this point. And an ApoB can really help distinguish between those two in this circumstance.
Exactly. Thank you so much for that. Go ahead, Marina.
Dinesh, sorry, I just want to intervene. Of course, if you have just the lipid profile and now all the scenario that Deepak presented, of course, this very high level of total cholesterol should make you think twice. And as Dan said, either LDL or LpX. But I just would like to point out the absurd level of HDL cholesterol that, because they are very, very rare, should raise you the suspicion that something fun is going on and these are not real. And so point towards LpX more than LDL. And also because in the differential diagnosis, you are thinking this level of total cholesterol are also in homozygous FH, but you will never see an HDL like that. So
That's a very
I also
good point.
would like to point out, if someone never saw St. Thomas in real life and just saw it through pictures, the palmar St. Thomas are very pneumonic. But if someone just noted the elbow, St. Thomas may think of homozygous FH. However, these are planar, and just a simple physical examination to look for tendinous St. Thomas and not having them will also point away from homozygous FH. And so
Yeah,
yes.
thank you for that point. And I'll just add to that, when you first see people with FH, even though they may not have the big nodular tendon Achilles xanthomas, but this was something Alan Brown always impressed on us. You feel for the tendon. You actually palpate the tendon between your fingers to see if there's thickening of the tendon, because that appears even before the actual xanthomas and the nodular growths begin to form. There's a couple of questions in the chat about why do the xanthomas tend to occur in these areas, and that's a really good question. It's because of what is depositing, and two, why is the propensity in certain parts of the body. So generally over the extensor surfaces and where there's friction and trauma, you'll see these kind of tubereruptive xanthomas that happen from either immune complexes or say chylomicrons or triglycerides. And for the remnants, they have a propensity to get into the palms, as does LpX. And then very, very high LDL levels typically lead to both xanthelasma as well as your tendon xanthomas. So, there's a lot you can learn from xanthomas, and where they happen and the context they happen can be very useful. Really like your point, Marina, about this HDL. That high of an HDL occurs very rarely. And in the context of what's going on here, it tells you it's an analytical or chemical problem with detection, and that's probably a spurious number. And we'll come back to that. So, all right. So Deepak, you want to move on? I think you're going to give us the ApoB at some point. All right. So here's our question. I think, go ahead.
So I think we were going to discuss what would be a differential diagnosis. I think we've already talked a little bit about that, and we were going to talk about the next steps in the investigation of whenever somebody sees a cholesterol levels like this. I think we discussed a little bit about that as well. So I think I'll proceed to the next step and show what exactly happened with her. So she was, based on this lipid panel, she was then referred to the endocrinologist at the transplant center here. Meanwhile, she was started on rosuvastatin and ezetimibe. And before she came to her endocrinologist, she was on these two medications, so statin and ezetimibe. And I think she had a 3-month follow-up lipid panel showing pretty much the same lipid panel, didn't change much when she was on these two medications. In December of 2023, like 7 months after she initially met the dermatologist, she was hospitalized due to a bunch of reasons. The most important being some chest discomfort, and these xanthomas were now painful. So for these two reasons, she sought care in the emergency room again.
Yeah.
And by the way, I feel obliged to say that if this patient were under my care, I would not have gone straight to a high dose statin and ezetimibe simultaneously in somebody with such advanced liver disease. I'm sure and I don't know if it was done simultaneously or whether it was done sort of stepwise and gradual with monitoring. But it's not to say that it's not safe to use statins or ezetimibe. It just, I would exercise some caution with using any drug that gets metabolized through the liver in somebody with advanced liver disease.
That's a great point, especially in somebody who has, is moving towards class C cirrhosis. That's where you usually land up in trouble. And as we'll talk about in a bit, LPX itself, once you understand the pathophysiology, you're like, are these drugs even doing much? So as you mentioned, the liver docs see this all the time, total cholesterol of 1,000, but rather than say, well, maybe these drugs aren't going to work in LPX. It's sort of a knee-jerk response. Let's just give these drugs and hope for the best. The second thing I want to mention is we didn't talk much about cytosterolemia, but the lack of responsiveness to statins in particular, not ezetimibe. Ezetimibe has a powerful response, but should make you think about cytosterolemia. But two things argue against that. So cytosterol usually it doesn't just pop up in a 25-year-old acutely. So it's usually, if you get it either in childhood, it's usually because you're transitioning over from a different feeding pattern to plant-based foods. And two, they can have large xanthomas. That's another condition that causes large xanthomas. But this story doesn't kind of fit with that. And then with ezetimibe, it should really have come down. So everything is pointing towards LPX diagnosis in this case.
So
you
then
have some labs for us finally.
we
Okay.
have some labs. Finally, we have the ApoB here. It's 120 milligrams. And ApoA was an A1. I was expecting some ApoA1 given that the HDL was 130, but that was not sent to this patient. But the HDL came back as 27. This was just like a few months apart. So this is kind of more what we would expect in a patient with this situation. So, yeah.
Well, I can't say that I would know exactly what ApoB to expect in somebody who has a total cholesterol of 900 when it's all LDL, since that's not a typical measurement that we do. And we have so few patients who have that. But my guess is it would be somewhere north of 400 milligrams per deciliter. And so anything less than that is markedly abnormal and tells me it's not LDL. And as Dinesh already pointed out, that's highly consistent with the diagnosis of LPX in this context.
Yeah. And I was going to let the audience know what Dan had mentioned earlier. There's actually a website called apob.app. It's not available on the phone, unfortunately. I don't think it is, but I use it all the time. ApoB, I'll put it in the chat, apob.app. And it's really useful in sort of having ApoB and total cholesterol and triglycerides guide you as to what underlying pathology it can be. And it's not always accurate. Like if you plug in the exact numbers in this case, I think the ApoB, it doesn't really list LPX, but you sort of get thinking along the lines as to why this is happening. So I find that website very useful. Marina, if we had an APO1 in this case, what would you have expected the APO1 to be? With right now the HDL is 27, but before when it was 130, I think it really helps you say, okay, well, the APO1 is normal, so I know the HDL is spurious, right? Is that something you use commonly to sort of really just clinch it down and get to the diagnosis and make sure it's spurious?
Yeah, I didn't trust that 130 of HDL. I'm not sure I'm trusting this 27 milligram per deciliter of HDL. This say to me that there are something that really interfere with the labs. The ApoA1 with a 27 would have been quite low. I don't know, Dan, do you want to suggest what it could be? You're much more experienced with me on seeing panel and these things.
You're so untrustworthy, Marina. You got to trust the labs when they tell you it's HDL cholesterol. There's an old paper by John Schaefer, a bunch of other authors, and Brian Brewer reviewing the lipid changes that take place in PBC, which is a similar condition to PSC, and is another cause for LPX. And sequentially, what you see is this persistently high HDL cholesterol in these patients until they reach stage 4, and then their HDL cholesterol bottoms out. and I think a big drop in the HDL cholesterol. So, and that's why I was teasing about the trustworthiness of the HDL cholesterol. I think the bottoming out of the HDL cholesterol from 130 down to 27 may be an indicator that there's actually been a clinical change in this patient with as she transitions to the sort of later stage of her disease.
Good point. Good point. I think in this case, one has to keep into account both possibilities. So one, it's been a while since we got, in terms of time duration from the prior HDL to this one, but it could also equally just be different techniques of measuring the HDL in the lab. So these are done in different labs. So one has to keep that in mind, but both excellent points. I haven't seen very many cases of very high HDL from genetic causes, like, the ApoA1 variants. But usually when I check those in those people, it's high. And it's, like 170 or so, normal being around 130, 150. But in this case, I bet the ApoA1 would have really helped you narrow down whether it's a lab error or is it genuine. That goes back to the point you were making, Dan, about when the liver disease progresses, you really get a drop in HDL and advanced liver disease. Okay, so we're getting closer and closer to the diagnosis.
So now, I can
Go ahead.
tell the next couple of investigations we have. So one is obviously because she came in with chest pain, we had a CCTA, and the coronaries looked pretty clean and pristine. Calcium score was 0. And the other, now we have some more kind of a deeper information that we got from the labs. And there are like a bunch of numbers on the screen. I can just walk through that. We have the lipid panel here. The total cholesterol, again, is similar to 900s. HDL remains low. Triglycerides remains okay. ApoB remains at 120. We obtained phospholipid levels, and that was markedly elevated at 12,229. The cholesterol esters were actually, this is actually saying, hi, this is when the cholesterol ester to free cholesterol ratio was quite low, which is typically, I think the normal cholesterol ester to free cholesterol ratio is around 2.5 to 3:1. Basically, 75% of cholesterol in the blood is esterified. But in this case, the free cholesterol was markedly elevated when compared to the cholesterol ester levels. LpLA was normal. Non-HDL cholesterol was 877. The total cholesterol to ApoB ratio was markedly elevated. Typically, the upper limit of normal is around 10 when you take 8 sex-specific ratios. But in this case, it was like twice the upper limit of normal. And if you look at the right side panel, the renal functions are normal. Liver functions kind of remain stable. Bilirubin is around 6.3. Alk phos remains around 1800. And INR is a little bit elevated. So lots of information here in this slide.
That ratio of total cholesterol to ApoB is millimoles per gram, isn't it?
Exactly. Yeah, I was just going to point that out. It's not milligram per deciliter for both. So you have to convert the total cholesterol into millimoles. So 900 divided by about 38 would be whatever it is, millimoles per liter. And then the ApoB is in grams per liter. So here it will be 1.2 grams per liter.
Okay. And then we also
Deepak, just looking at the free cholesterol to cholesterol ester ratio, so as you mentioned, usually 70% of the cholesterol that is circulating is cholesterol ester. The fact that there are much more free cholesterol than cholesterol ester should already give you suspicion of cholestasis and LpX being present. Yeah. Sorry, I interrupt you.
No, that's a great point. It's a very good teaching point.
Yes. And this was the lipoprotein electrophoresis that was sent to Mayo Clinic. And we have a big additional band near the cathode region, close to the LDL level. And this was, again, diagnostic of LpX. But I think this is what most clinical centers use. And I think based on this, the team was able to confirm the diagnosis of LpX.
Marina, how often are you using this? And can you walk the audience through, what do you expect to see in terms of normal bands and why the HDL is running towards the anode? And where's the LpX in that sort of broad smear?
Yeah, Dinesh, I don't know for who is old enough, electrophoresis was practically one of the first way in which we could test, cholesterol levels and lipoprotein. It retained a very important role in detecting LpX. LpX is a very funny lipoprotein. There is very little protein. There is very little hydrophobic core, like the other lipoproteins are. And when you apply it to a gel, an agarose gel like this one, the slide point, the application point, and every lipoprotein that we know of, LDL, HDL, VLDL, run towards the anode, towards the plus. The LpX, because of his composition, it runs counteractive. It runs towards the negative, the cathode. Mayo Clinic does a very smart things, and it just ultracentrifuge your plasma samples to take out the VLDL, because the VLDL will a little bit overlap with some of the big bands that you see on the patients and make not very clear the movement towards the cathode. So in this gel, you'll see a very good band of LDL, a very faint band for HDL that maybe suggests that the patient really have a 27 or very low level of HDL. But most importantly, you see that smear towards the negative that is pathognomonic of LpX. So this is the test to be done if you want to be certain that this patient has LpX. Deepak, I don't know if you're showing something about NMR later on, so maybe I'll do something. I'll make some other comment on that.
Sure. Sure. Yeah, I'll definitely show it. I think we have like an audience poll question coming up. So I'll get that in and then move the slides there, show some NMR slides as well. All right, perfect. And just want to start with the first audience response question of the day. Which feature is the most confirmatory for the diagnosis of LpX? A is the presence of severe hyperlipidemia and xanthomas. B, the presence of jaundice and xanthomas. C, the presence of elevated free cholesterol and liver disease. And D, the presence of severe hypercholesterolemia, elevated non-HDL ApoB ratio, and cholestatic liver disease.
Chloe, do we get to see how many are answering and what the
I'll try to
responses are? Oh, there we are. I spoke too early. So looks like the majority of people got the correct answer. So 53% said it would be the severe hypercholesterolemia in the context of cholestatic liver disease and an elevated ratio of non-HDL to ApoB. So either non-HDL to ApoB or total cholesterol to ApoB. Either one of those would work. So fantastic job. I think, Dan, your message is really getting across. So
I can pull the slide about NMR spectroscopy if you would like to talk about that, Dr. Cuchel. Would you like to talk about that?
You can go ahead and show everything.
There you go. This is the slide.
Oh, no, my goodness. Okay. So I was just going to mention that the other method that you can, in which you can now suspect or detect LpX is through NMR spectroscopy. There is a new algorithm that now can detect it as you see it on, for example, on the panel B that you are showing. But I wanted to point out that sometime through the NMR profile, you can also detect not only LpX, but also another abnormal lipoprotein that is LPZ. So the case that you presented, Deepak, it's really an extreme case where there is so much free cholesterol that is not even doubts on the eyes of an expert that there is LpX. But maybe some patient with cholestasis may have not such an increase on cholesterol. And so you may really need to dissect a little bit the differential diagnosis. And it could be this beta lipoproteinemia or any other. But lipoprotein Z may be a way in which you can think, okay, it's due to the cholestasis and it's just because there is not a huge amount of free cholesterol, but there is this funny large LDL that is much more rich in free cholesterol than not the normal LDL and etc. So if you are not certain and the band in the gel for LpX is not so clear like the one that you show, the NMR with the lipoproteins that may help you for the diagnosis. So.
Exactly. I just put in the chat for those that are interested. LabCorp does this, and we had heard from Alan Rumeli about, if you really are suspecting LpX, it's good to give the lab a heads up. So call them and tell them to, separate out the LpX. They may even be able to quantify it for you in certain cases, but you will get a report saying there is LpX, but it's best to call them ahead of time if you're really thinking in that direction. So Dan, I think you had pointed out very nicely, in this case, really could be nothing else. When you have a total cholesterol that high and you've ruled out FH and your ApoB is sort of normal, and Deepak, maybe you can throw that chart up there about how to work through this. If you get an ApoB and then you sort of confirm it with a poor man's test, which is a free cholesterol to cholesterol ratio, I think you're done. You don't even need these fancy tests, but it's not, if you want to get them, just so you can confirm it. We got it because this lady was like, I don't want to get off my meds with a cholesterol that high and I'm having chest pain, which is why we did the CT and sort of did this just to reassure her that she could get off the statin. But this is sort of a flow chart showing you how to think about this. And, the two ratios which we find most useful are your ratio of total cholesterol to ApoB and free cholesterol to cholesterol ester. How often are you, Marina, seeing these people order tests for LpX? Because it's not that uncommon, I would suspect, in the milder cases of liver disease, maybe minuscule amounts, but most people don't think about it. We kind of think about it only in these extreme cases. Are you seeing a lot of these tests being ordered? Probably not.
So this probably is a question for Dan, because I'm a sort of mouse lab person that does research on my on my FLD patients. So I do not see a lot of patients with disease other than familial LCA deficiency that could have LpX. But Dan referred to the lab quite a few patients, and I think you order quite a few tests, correct?
Yeah. I would say besides, the testing is actually kind of the easiest part here. You just want to confirm the diagnosis. When you get a dramatic change in the cholesterol, there's very few things that will cause that dramatic change. And, what we'd see in a lipid clinic would be perhaps a very unusual, a so-called lean mass hyperresponder who's on a ketogenic diet could induce a severe hypercholesterolemia, which is associated probably with accelerated atherosclerosis, and that's where that CCTA would come in handy, or LpX, where the LpX particles are in high concentration, probably not atherogenic. I'm not going to say definitively not, but probably not atherogenic, possibly even atheroprotective. and where you wouldn't be at all surprised that the CCTA was normal, especially in this young woman who otherwise doesn't have other atherosclerotic risk factors. And, so I think it's useful to keep in mind the warning that I said earlier that there's very few lipid emergencies, but the total cholesterol over 1,000 does have some emergent concerns, but it's not about the atherogenicity of LpX. It's because it can cause other problems. And the main other problem that it can cause is hyperviscosity.
Exactly.
Yeah, I
Deepak,
think,
you want to talk a
yeah,
little bit about this and the
yes.
hyperviscosity?
Yes, I think our patient did not have a hyperviscosity syndrome, but she had painful xanthomas, and that was seen as a kind of a good indication for her to actually undergo plasmapheresis. I would say actually plasma exchange is actually a better term in this case when compared to plasmapheresis. So this patient was placed on the liver transplant list. She underwent a liver transplant. She was discharged on all the immunosuppressants. And this is a post-op lipid panel, so complete resolution of her LpX. So this is typically what we would expect to see. And in terms of plasmapheresis, I think I have a slide in there here. This is like a beautiful picture actually showing how does a plasma of an LpX patient. The middle tube is the sample from a patient who had high LpX. And on the right side is after plasmapheresis, when you still have a high amount of bilirubin. So that's why you still have that yellow tinge to it. But otherwise, the left, the burst tube is the control tube. So typically, we start plasmapheresis for marked LpX concentration, and patients have some symptoms of hyperviscosity. There's confusion, vision disturbances, and central retinal vein thrombosis, pulmonary embolism, cholesterol granulomas. Again, this is like a therapeutic plasma exchange showing the yellow mustard color of somebody who has LpX in their plasma. And
Deepak, I wanted to point out that the first patient that I mentioned at the beginning, who was in the ICU, when I went to the ICU to go see the patient, but I didn't have the patient's name, and I asked the nurse at the station, I'm looking for a patient. I'm a lipid specialist, and I didn't get the name, but I know they have this very high cholesterol. And the lipid specialist, and the nurse said, "Oh, you mean the lady with the really thick blood?" And the nursing staff who was drawing her blood had noted that the blood had become really thick and almost gelatinous, and that was something that caught their attention. And I think that's a very unusual thing, but that would be an example of a pretty obvious hyperviscosity syndrome.
Yeah. And I think just adding a little bit to the point I talked earlier about therapeutic plasma exchange versus plasmapheresis, because these particles lack ApoB, using traditional plasmapheresis methods such as heparin or adsorption or cascade filtration, they really don't absorb these particles out of the bloodstream. So plasma exchange, as opposed to lipoprotein plasmapheresis that we typically do in patients with homozygous FH, is probably more responsive in this condition. It's just more.
Yeah. Good point, Deepak. So lipoprotein apheresis, which is used for several diseases, including high LPA or FH, as you pointed out, typically relies on moving one lipoprotein. And so if you're going to use ApoB, dextran sulfate apoprotein lipophoresis, it wouldn't work in this case because, as you said, LpX does not have ApoB. Plasma exchange is sort of, you take the plasma out, you filter out whatever you want to filter out, immunoglobulins, or in this case, LpX, and then you infuse donor plasma or albumin to replace the volume removed. I think what we'll do is, in the interest of showing some of your fantastic slides, is we'll go over 10 minutes. The CME is only for 1 hour, but Dr. Mintz is saying we're allowed to go over by 10 minutes for the audience members that want to stay. You're welcome to, and we'll be taking questions up until that point. But we do want to give a few summary slides. Deepak has spent a lot of time doing great work on this. So Deepak, maybe show us what LpX is. I think we've been sort of got into that, but you have a slide on what is LpX and how does it happen? Yeah.
Sounds good. So obviously LpX, we have talked a lot about it, is an abnormal protein that develops in cholestatic liver disease. The other common conditions are LCAT deficiency with parenteral nutrition with lipids, Those are the two big conditions. It does not contain ApoB and therefore does not interact with the LDL receptor. It's catabolized predominantly by the reticuloendothelial system. And this is like a transmission electron microscopic image showing the classic discoidal lamellar onion skin appearance of LpX. And then again, this shows a little bit about the biophysical characteristics of the LPL particle. Its density is probably similar to between that of LDL and HDL, I believe. Phospholipids is the biggest component of it. 60% of it is composed of phospholipids. Free cholesterol forms a big portion of it as well. 26% is free cholesterol. Only 4% is just cholesterol esters. And there are small amounts of ApoA1C, when I looked into literature, there were quite a bit of topics about LpX subfractions like X1, X2, X3. I don't think they really hold good in contemporary studies, but just out of interest. And then we talked a little bit about the big classification in terms of the etiology of LpX, cholestatic liver disease associated, and then that is associated with LCAT deficiency and lipid infusion. We talked a little bit about the differential diagnosis for somebody who has very high cholesterol. So I'm not going to go spend too much time on that. The formation of LPX has been, there are multiple hypotheses, but essentially I think the biggest concept is that biliary excretion is impaired in cholestasis. All the accumulating phospholipids, cholesterol, and ApoC kind of mix with albumin. They form LPX in the biliary canaliculi, and they reflects back into the plasma. So that's like the kind of the prevailing hypothesis at this point of time. And because we talked a lot about cholestatic disease, the one we didn't talk much about was LCAT deficiency. And here I'm showing the slide that shows a simple reverse cholesterol transport pathway. And LCAT, when combination with ApoA1, in addition with the ABCG1 and A1, is responsible for estrifying cholesterol from free cholesterol to cholesterol ester. And that is again transported to the liver or exchanged with the LDL or VLDL particles via CETP. So when you have a deficiency of LCAT, you have a big backlog, and all the accumulating phospholipids and everything contribute to formation of LPX. And there was a good point raised by Dr. Soffer about whether LPX is atheroprotective or not, in the sense that because it really doesn't cause the endothelium, there is some people, they're saying it's not only doesn't cause atherosclerosis because of its other properties, such as preventing free radical oxidation and so on, it may be atheroprotective. There was an interesting study that was actually done in patients with LCAT deficiency, where patients with fisheye disease, which is like the partial LCAT deficiency patients, lack alpha activity of LCAT, but they have preserved beta activity, which means you still estrify cholesterol in LDL and VLDL. These patients can continue to develop atherosclerosis. So I think that's one of the points, saying that if the ApoB is sufficiently high in the setting of other risk factors, one can still consider treatment of patients with high LPX. And in patients with familial LCAT deficiency, where you have reduction of both alpha and the beta activity, you don't have esterification of cholesterol in HDL, LDL, and VLDL. And therefore, these patients are somewhat protected from developing atherosclerosis. Either of these conditions, if you treat them with recombinant LCAT, LPX completely goes away. So that's an interesting thing I wanted to talk about as well. But other than that, I think we have covered most of the information. Anyway, this is an interesting slide. I think this highlights the point we talked about earlier, having faults, the electrolytes, as well as the lipid panel that can be affected by very high LPX. You can have pseudo hyponatremia, pseudo hypokalemia, pseudo hypochloremia. You can have sometimes high HDL, sometimes low HDL, both due to different techniques that was used to measure HDL levels. So this is an interesting thing to be aware of in patients who have high LPX. You could have abnormally high or low parameters. I think that's about it. I think we've touched most of the other points during the discussion. Yeah.
Great. I think there was one question in the chat,
Yes.
which is a very good question about why doesn't everybody with cholestasis get high LPX? And I have an opinion about it, but Dan, maybe you want to answer that? Because you've done really a lot of work on thinking about, liver injury and liver disease and how that changes the lipid profile and LpX formation.
Your question is, why doesn't everybody get LpX?
Yeah, I mean,
I
I
have
think it
no
just
idea.
depends. Yeah, I think it's just a degree. But if you think back about what happens in LpX, it's essentially you get excess bile stasis, and that bile essentially contains a lot of phospholipids and bile salts. And as that refluxes back into the biliary canalicular space, there's some controversy if it's just passive reflux or it goes into the hepatocytes, and the hepatocyte actually transcytoses the phospholipids and bile salts via ABCB4, but eventually it lands up in the sinusoids, and the physical chemical properties of having such high free cholesterol with the phospholipids tends to form LpX, and that's been shown in experimental models. In fact, when they ligate the bile ducts in these experimental models, you see LpX within a few hours, but it's got to be severe enough. So I think practically, and nobody's shown this, I think be a really nice study to look at, is, when people have mild to moderate cholestasis, we aren't really doing these fancy tests for LpX. We just kind of see a slightly high cholesterol and we say, okay, well, that's fine. It's just when the cholesterol is 1,000, then people really start thinking about this and checking it. But I'm sure if one checked it and had really good ways of quantifying it, which we don't have at the moment, we sort of get a binary output. Yeah, you've got a ton of LpX that's seen on the electrophoresis or NMR, or, nobody's thinking about it. If there was a way to quantify low levels like high sensitivity troponin, you would see it in a lot more patients because it just makes sense with the physiology of cholestasis. So that was a great question. I thought about that similarly. And there's one more, which I'll let any of you guys take, including Deepak or Dan. So explain why there's no benefit of statins or ezetimibe in this condition. I think that's a great question.
Yeah, I think Deepak hinted at it earlier that the ApoB is the principal ligand for the LDL receptor, and the LDL receptor is upregulated and hyperexpressed when you treat with statins and ezetimibe. Typically, in this case, you can't clear particles if they don't have ApoB through the LDL receptor, and I think that's probably the most important reason. Also, as the disease progresses, LpX itself actually suppresses LDL receptor expression, so it's a sort of a combined reason why even you're probably not going to even clear LDL as efficiently as you would in this circumstance.
Precisely. Yeah. And the same thing with ezetimibe, when your intrahepatic circulation is interrupted, cholestasis, your your ABCG5 efflux is already at its max. You're trying to pump out as much cholesterol you can, and so inhibiting that ain't going to help anymore. So that's a reason that doesn't work very well either. So really, there's not very many drugs that work well in LpX to lower the LDL, aside from just fixing the underlying problem. So you either relieve the cholestasis or you give these people with DBC or PSC a new liver, because that's the only thing that helps.
Yeah, so
Dinesh, may I try to answer the question about why not every patient develops LpX? And I'll take 2 minutes really. I really truly there are several reasons certainly, but I think one of the driving force will be the amount of free cholesterol that these patients have, and this is just based on the genetics for LCA deficiency. There are 2 flavors of LCA deficiency. One is the fish-eye disease, and one is the familial LCA deficiency. Because, as Deepak said, the familial LCA deficiency is a total lack of LCAT activity. There are much higher levels of free cholesterol, and only those patients develop LpX. FED, fish-eye disease, do not develop LpX. And in their case, the free cholesterol to cholesterol ester is a ratio about 1:1, 50-50, while in the familial LCA deficiency, the ratio is much more skewed towards free cholesterol. So, and if you want to test it, I would advise you in the moderate, in the modest cholestasis, I would suggest you to do NMR profile versus the electrophoresis, the gel, because then you can look at the lipoprotein Z, and that may be altered in these patients.
Yeah, that's a great point. Yeah, absolutely. So lipoprotein Z, as you know, is more alcohol hepatitis related. But for smaller quantities of lipoprotein elevations, I think NMR outshines electrophoretic quantification, semi-quantification. Okay, Deepak, you want to start wrapping up? I think you had
Yes.
another audience
We have one
question,
last
didn't you?
audience response question, and then we should wrap up. All right. So, which of the following laboratory tests is not useful for detecting the presence of LpX? A, lipoprotein electrophoresis. B, direct LDL. C, ratio of free cholesterol to esterified cholesterol. D, total cholesterol to ApoB ratio.
Well, amazing audience. They got it right. So unless you're doing beta quantification, the LDL cholesterol direct or homogeneous assays are going to be inaccurate. So a great response. I think they got the topic really well. And you have your take-home slide.
Yep. So just take-home messages. So suspect lipoprotein X in patients who have markedly high cholesterol in the setting of cholestatic liver disease and low ApoB. And other clues include total high. Sorry, we went back. Other clues include high cholesterol. I think I lost it. Okay. Other clues include high total cholesterol to ApoB ratio and high free cholesterol to cholesterol ester ratio. Consider lipoprotein electrophoresis or NMR spectroscopy for diagnosis. Treatment is primarily focused on the underlying condition. Consider lipid-lowering therapy based on ApoB levels and other ASCVD risk factors. All right. And that's it.
Okay, well, I want to thank this illustrious panel of superstars for presenting a unknown case or a little known case, and now everybody 93% plus know a lot about the disease. So thank you, Dr. Kalra, Dr. Soffer, Dr. Vedamurthy, and Dr. Cuchel for bringing LpX to life. I want to thank the audience for joining us for tonight's lipid panel. Next month, the lipid panel is earlier because we compete with Thanksgiving. So the panel will be on November 18th. So it's Tuesday, November 18th. It's going to be a lipid panel talking about triglycerides or chewing the fat. So I would invite everybody to join us for that. And once again, thank you to our superstar team for this evening's presentation. Have a great night.